Welcome back to Master USMLE. I am Dr. Amin Afrasiabi, and today we are tackling a high-yield, high-stakes emergency that can make or break your Step 2 CK score, cardiogenic pulmonary edema. This is not just an exam question, it is a condition you will see in the hospital. Picture this. A 68-year-old man arrives in the emergency department gasping for air. His blood pressure is 210 over 110. Heart rate is 112, respiratory rate is 32, and despite high-flow oxygen, his oxygen saturation is still dropping. You hear Crackles and S3 gallop, and he is struggling to breathe. What is happening, and what is your first move? If you hesitated for even a second, do not worry. By the end of this episode, you will know exactly how to recognize, diagnose, and treat this critical condition. What's going on? Understanding cardiogenic pulmonary edema. Let's start with the basics. Cardiogenic pulmonary edema happens when the left ventricle fails to pump blood forward effectively. The biggest triggers include hypertensive crisis, acute decompensated heart failure, and myocardial infarction leading to pump failure. When the left ventricle cannot keep up, blood backs up into the lungs. This increases pulmonary capillary pressure, forcing fluid into the alveoli, and that is where the real trouble starts. Key signs you will see on exams and in real life include severe dyspnea and orthopnea, which are worse when lying flat. Crackles on lung auscultation, indicating fluid accumulation. An S3 gallop, which is classic for left ventricular failure. Hypoxia despite high-flow oxygen, because the alveoli are full of fluid, not air. This is an emergency. The longer you wait, the worse it gets. So let's talk treatment. The game plan, emergency management. When a patient is crashing, what is your first move? Forget about labs or additional tests. We need to fix oxygenation immediately. Your three priorities are non-invasive positive pressure ventilation, or NIPPV. Diuretics, typically furosemide. Vasodilators, such as nitroglycerin, if the patient is hypertensive. Now let's break down why these treatments work. Why does positive pressure ventilation work? Positive pressure ventilation does more than just push oxygen into the lungs. It actually changes cardiac dynamics in a way that rapidly stabilizes the patient. First, it reduces left ventricular preload. Increasing intrathoracic pressure decreases venous return to the right heart. Less right ventricular preload means less left ventricular preload, which helps relieve pulmonary congestion. Second, it reduces left ventricular afterload. The left ventricle does not have to work as hard to eject blood because positive pressure ventilation lowers systemic vascular resistance. Third, it literally pushes fluid out of the alveoli, restoring oxygenation, reducing the work of breathing, and buying time while other treatments take effect. The key takeaway is that NIPPV is the #1 intervention in cardiogenic pulmonary edema. Use it early. Medications fixing the underlying problem. While NIPPV provides immediate relief, we still need to remove fluid and reduce the workload on the heart. That is where medications come in. First, loop diuretics like furosemide are first-line treatment. They not only remove fluid but also have a venodilation effect within minutes, reducing preload even before diuresis begins. Second, vasodilators like nitroglycerin are best for hypertensive pulmonary edema. If blood pressure is elevated, nitroglycerin is the preferred option because it reduces both preload and afterload. Third, inotropes such as dobutamine or milrinone are needed if the patient is in cardiogenic shock. If systolic blood pressure is below 90, an inotrope can help improve cardiac contractility. Key USMLE tip. If blood pressure is high, use nitroglycerin. If blood pressure is low, consider inotropes. Always use diuretics unless the patient is in severe shock. USMLE style question. Can you answer this? Let's test what you have learned. A 72-year-old man with a history of heart failure presents with sudden shortness of breath. He is hypertensive, tachycardic, and hypoxic, despite high-flow oxygen. He has diffuse crackles, an S3 gallop, and severe dyspnea. What is the best initial treatment? Think for a second. The answer is non-invasive positive pressure ventilation, or NNENSIP-PV. Why? It rapidly reduces preload, afterload, and lung congestion. It improves cardiac output and oxygenation. It has a proven mortality benefit in cardiogenic pulmonary edema. If you picked intravenous diuretics first, it is not necessarily wrong, but NIPPV is your best initial step when the patient is in respiratory distress. Final takeaways. To summarize, cardiogenic pulmonary edema is due to left heart failure causing lung congestion. The key symptoms include severe dyspnea, Crackles, an S3 gallop, and hypoxia. First-line treatment includes positive pressure ventilation to reduce preload, afterload, and improve oxygenation. Diuretics to remove fluid overload. Vasodilators if the patient is hypertensive. If the patient is in cardiogenic shock, consider inotropes. The biggest takeaway is that NIPPV saves lives. Do not wait to use it. That is a wrap for today's episode. If you found this helpful, subscribe to Master USMLE on Spotify, Apple Podcasts, and YouTube. For exclusive study guides and bonus episodes, check out my Patreon.